2, 1, please start.
Namaskar and good evening, everyone. I welcome you all for today's webinar on Onco Update 2024. And with immense pleasure, I would like to invite Dr. Rajat Sa, who is Senior Consultant and Unit Head Medical Oncology at prestigious Rajiv Gandhi Cancer Hospital, Delhi, for the welcome and introductory note. Over to you, sir. Take proceedings further.
Thank you very much. Thank you. And I welcome all of you for this webinar on the updates in lung cancer in the year 2024. So we have quite a learned panel of speakers and who will be taking us forward in this webinar. Lung cancer, definitely, as we know, is one of the most common cancers to afflict males in India, and the incidence is definitely rising manifold amongst females also. We Asians are one of the unique subset of lung cancers whereby maximum research and maximum, I would say, path-breaking research has come up. We Asians have the highest percentage of EGFR mutations as compared to the other parts of the world, and that gives us an advantage of treating our patients with good targeted agents against the EGFR mutations. The poster child of the treatment of EGFR anti-EGFR drugs is definitely osimertinib. This drug has in the past 3 to 4 years has proven its worth in various settings. We have given it in the metastatic setting. It has definitely also in the adjuvant setting trial has also been successful, and subsequently the most recent trial of the combination of osimertinib with chemotherapy is also definitely showing promising results. So to start the proceedings, let us first start from the basics, and then we can build upon our program. So I would like to invite Dr. Syed Nisar. He's assistant professor in the Department of Medical Oncology at the prestigious Sher-e-Kashmir Institute of Medical Sciences at Srinagar. Dr. Syed Nisar would be giving us an overview of lung cancer. And once we are on the same, once he gives us overview, then we will be definitely moving ahead in the agenda and speaking more about osimertinib. So over to you, Dr. Syed Nisar, for your talk on overview of lung cancer.
Good evening, sir. Thank you for the invitation and the introduction. Can I start?
So your
Yes, sir,
voice
yes,
is very
sure.
low.
Is it okay now?
Your voice is not coming through, Dr. Syed Nisar. Somehow either you're too far away from the speaker. We are not able to hear you very well.
Hello. Am I audible now?
Now it is definitely slightly better.
Okay. Is it now better?
Yes, yes, yes.
So thank you, Dr. Rajat and AstraZeneca for the invitation. So as introduction has been given, we'll be discussing the various in various lectures the management of lung cancer. And to begin with, we'll give overview of the management. So the burden of disease is high in India. So as per the Global 2020, so lung cancer is the fourth incident cause of cancer in India. But as for mortality, but as in men, it is the second commonest incident cause of cancer. So, but as we know that although the burden of disease is uh, high, but the incidence is around 5.5% of all the cancers, but mortality is much higher, 7.8%. So, in addition, we know that the staging has changed as per AGC 8th edition. What was like 1B more than 4 centimeter tumor in 7th classification of AGC has been shifted to 2A, because this has treatment implication. Also, as we can see that there's a stage shifting, like 2B has gone to 3A, then stages 3A has been shifted to 3B, and 3B has been shifted to 3C. So because this has been devised to add on the treatment to improve the survival. So the basic investigation in any lung cancer starts from, so in addition to basic image like CT and a bronchoscopy, most of times if we have central lesion, then of course, unless we have a clear-cut advanced disease, we do a PET stage for staging. In addition, for nodal staging in mediastinum, the non-invasive methods like EBUS and complemented with EUS. The mediastinoscopy, most of times we avoid, but definitely some stations are not accessible in EBUS and EUS, so we have to go for invasive stage like mediastinoscopy. And of course, in almost all now curable malignancy, and in addition, advanced also because of the improved survival of lung cancer, we do routinely contrast enhanced MRI brain for staging. So classically on imaging, if we have a node more than 1 centimeter on short axis, so it is a predictor of malignancy. But the caveat is that routine CT has limited sensitivity and specificity, although it does help in localizing the lesion and getting biopsy. And this has been improved by the advent of PET-CT, and this has increased the sensitivity to the tune of 90%, and as well as specificity to up to 95%. So we have to remember that once we stage any lung cancer patient, we have to see the predictability of OCL and 2, because that changes the management, and that may change also the intent of treatment like non-surgical. So this classically, we should remember that once we go towards the center, though there are high chances of OCL nodal N2 max, as well as once the size increases from T1 to T2. In addition, we have to remember that SUV also has an implication on OCL nodal. If we have a SUV of less than 4, it is around 2%, less than 2% OCL nodal matter. But if it goes more than 4, it goes to the tune of more than 10%. So central tumors, the size more than T2, and higher SUV, more of the chance of OCL and 2 disease. So in addition, we discussed like less invasive medicinal staging like EUS and EBUS. So they complement and they are using the different nodal stations. Invasive we have like conventional, and then the VATS associated different modalities. So they may be used. One we have you can see from the slide that on the right hand side we have proclavicular, then we have sphere mediastinum, usually up to, and 4, then we have aortopulmonary 5, 6, 7. Then if you medicinum at 8-9 stations, then of course we have 10 to 14. They are like hilar, interlobar, and peripheral zones. So if we have a clinical suspicion of anti-involvement, and after even like negative EBUS and ES, then surgical staging with medistinoscopy. And most of the times we do on the surgical table itself. So then should we strongly suspect that we have to go for this uh, medicinal staging? If we have a centrally located tumor, size is more than T2, extensive infiltration of mediastinum with no evidence of extrathoracic disease. So, but if we have a bulky N2 disease on CT, we don't need to go for invasive this because it is presumed that is a positive disease. But if we have a discrete N2 disease, yes, regardless of the PET CT result, we have to go. So normal medicine on CT, but positive on PET, so of course we have to go. But if it is negative, then we need not to go for invasive imaging for the medicinum. So this is the algorithm for medicinal staging. So once we do PET for intrathoracic lung cancer without enlarged nodes on conventional CT, if we have negative medicinal lymph nodes, so clinically N0 and low probability of unforeseen N2 disease after negative PET, but we have seen the probability. So we go for surgery, or if it's a small lesion or there are other issues, we can go for radical radiotherapy. But if we have clinically N1 or N0 and high probability of unforeseen N2 disease after negative PET, so we confirm by EBUS or US. If we positive, we go for multimodality treatment. If we are negative, then again surgery or radiation. But if you have positive lymph nodes on imaging and they are bulky, we need not to confirm. But if they are non-bulky lymph nodes, we need to confirm by tissue. So if they are positive, then multimodality treatment, then negative, again multidisciplinary evaluation. If they are negative, then surgery, positive, then again multimodality treatment. So lymph node stations and so how we can fix. So we have to remember that all the investigation, they have their own issues, so they will not always pick up all the nodes for biopsy or FNAC. Conventionally, like we use the non-invasive like EBUS, TNA, and US, so they have high sensitivity and pickup rate for like station 2, station 3, 4, and then 7, like, and 10. But here, if you see US TNA, they will miss 5 and 6, so they cannot assess those. And here in they like station 8 and 9, we count US, and they most of the times pick up left side nodes. And if we do medistinoscopy, and they complement these stations, and they have a different approach and different pickup rates. But overall, if we see that the highest assessment and is with the VATS, and again, if you go left and right, in left, there are some stations which are left and they are picked on the right VATS. So we have to actually force in the imaging which stations we need to see and then choose the imaging. So this is again depicting the same sensitivity in different stations like CT, PET, and different modalities. So if we go to the evolution of the therapy in lung cancer, so conventionally we'll consider it as a single disease a long ago, and then we had the classification of non-small cell and small cell, and depending on the histopathology we'll treat them. Non-small cell again were divided into like squamous, and non-squamous then came large cell and adeno. Then was the era of where we could pick up like their molecular signatures like EGFR, ALK, and ROS, and this we can see in later slides. The armamentarium has increased much, and then came like PD-L1 expression. So we started dividing patients on the basis of less than 1 to 40, more than 50. And also now is a tumor mutation, but less than 2 mutations per megabase are more than or equal to 10. So Of course, we know that with the advance, although the incidence has decreased so it's slightly, but the survival has also shown to be improved with the advent of different treatment modalities. We can see that classically the advance has been made both in the targeted specific targets and immunotherapy. It started with chemo in 2006-9, then different doublets were chosen, then Temtrexil was in 2009, then came the era of targeted like crizotinib and ALK in 2011, then erlotinib 2013, and then this went on so till we have many like we have osimertinib, and then we have anti-alecannival drugs. So that is also true with the immunotherapy, and there is a significant tremendous advance in the immuno-oncology. So we had pembrolizumab for more than 50% advance in lung cancer, then it came with chemo, then it came with 1 to 50, then atezolizumab, then and then different agents were added to the field. So if you see as of now, so this has now become much more complex, but classically we target these as like EGFR, alloCross. We have the approved drugs, NTRK, MET, and RET. Now lately we have drugs like trastuzumab deruxtecan for HER2. So there's this increase the need for molecular testing in any non-small cell, and it should be the standard of care. So we can tailor the treatment and we can choose actually the specific drug. So as for the treatment from conventionally, if you have early stage needs observation like 1A, so in stage 1B and 2 high risk, we need add-on chemo. In stage 2B, adjuvant chemo, and there's no benefit of neoadjuvant conventionally, but if we have stage 3 and 3B in addition to chemo, we may need radiation if we have N2 disease, or we may sometimes use concurrent or sequential chemo RT. So radiation in addition to N2 disease, if we have positive margins, again is indicated. So, or elsewhere, if you have very early disease and there's age and other constraints for surgery, we can use like SBRT, especially in case for lesions. So, with this all background, we still understand that although we have achieved much, but still half of the patients they relapse. So they can relapse systemically or locally, and so this is the patient pool that we try to improve their survival by targeting the different agents. And lately we had evidence that stage 1B has definite improvement with adjuvant chemo, and in fact it has been in latest classification change 2A. So this especially more than 4 centimeters has shown increase in improvement in survival with the add-on chemo. So this was a meta-analysis which showed that with the previous conventional chemotherapy, there's overall around 5% improvement in survival, and neoadjuvant, adjuvant, they had shown almost same. There was no difference whether we do before or after surgery. So now we have added many more agents which have actually been added to the adjuvant standard chemotherapy, and this ADORA trial shows that patients completely resected 1B to 3A which had EGFR mutation, and they were classically given placebo or the control or the osimertinib for 3 years. And you can see the hazard ratio 0.2, which is almost unheard in clinical trials in oncology. So much was the improvement. So this has changed the landscape of treatment of EGFR positive operated lung cancer patients. So decreasing mortality by 80%. So this has become the standard in EGFR positive after surgery in adjuvant setting. So similarly, we have atezolizumab, especially if we have PD-L1. This has shown in improvement in survival from at around 3 years, from 48 to 60%. Then radiation, different modalities have newer model. They have also shown in improvement. We have like IMRT, IGRT. So with these, we have been able to give the folks a dose, decrease the toxicity, and improve the survival. So these are the different like SBRT if you have small volume, folks disease, IMRT if you have a bigger volume. So for the planning, have to, and all this has improved the outcome, decrease the toxicity, and then concurrent collateral damage. So this is again depicting the same that we have improved on the radiation as well. So this already discussed. In addition, that we have seen with the Pacific trial, this landmark trial shows that in case of inoperable to stage 3 non-small cell lung cancer, after the curative intent concurrent chemo RT durvalumab for 1 year has improved the survival. So you can see that here from 33 to 42%. So durvalumab demonstrated around 42.9% OS at 5 years in comparison to historical OS in unresectable stage 3 at 5 years of around 15 to 20. So this is something which was unheard. So they are emerging targeted as well as immunotherapeutic agents. So we had in advanced TKI like osimertinib compared to the first generation TKI. Again, you can see median PFS almost doubled, 10 to 18 months. This was true with ALK positive patients from so again 10 to 34 months. So newer drugs against MET exon 14 alterations or amplification against RET, NTRK, and HER2, they have all been added, and these targets they have been able to increase the survival in the subset of patients. So this is a busy slide, but what we can infer that as well as the conventional, the survival around less than 1 year, it has gone beyond 4 years. So again with the immuno, so we can see that we started 2015, then in 2020 we have many drugs. So both in neoadjuvant, adjuvant, as well as metastatic setting, and all have been able to improve the survival. So in different settings. So if we see again, so around 4 months to 6 months, then it has gone to 9, 8 months. Then here we can see 30 months, then 20 months. So in different trials and depending on the type of patient profile as well as PD-L1 expression and the immunotherapeutic agent used, so they have shown dramatic improvement in the survival. So this is with the checkpoint inhibitors in stage 4 advanced, you can see from 16 to 35, 31% improvement in survival. So this keynote 024 showed an improved survival in patients with pembro compared to chemo with PD-L1 PPS more than 50, so almost 32%. We can imagine that the patients were alive at 5 years with the use of in metastatic. So multiple ongoing trials in adjuvant settings we have not seen with data with nivolumab in neoadjuvant as well as adjuvant durvalumab, then pembrolizumab, then atezolizumab. So especially in stage 3 and PD-L1 positive, they have been able to improve the pathological composition and PFS, and then we'll see OS as well. So then antibody drug conjugates like we had using breast, we have discussed like trastuzumab deruxtecan, which is already approved in second line in HER2 positive metastatic lung cancer, and then CAR cell and newer agents are coming to this, so which utilizes body's own cells, and then we take out, then we modify, and then we introduce into the body, which fights against the tumor cell. So the take-home message is that the management landscape is fast changing in non-small cell lung cancer. Newer therapies have a huge potential to improve survival, especially when detected in early stage. OS has improved across various subtypes with molecular alterations. The ease of oral pill or infusion in case of targeted is an added advantage, and polymorphs will have to play a huge role in early diagnosis, so it is crucial to involve them in non-small cell lung cancer. Thank you for your patience.
Thank you very much, Dr. Syed Nisar. That was a very comprehensive review of the entire lung cancer, from all the targeted therapies. You've covered checkpoint inhibition therapy, you've covered the role of radiation therapy, and also the basics of the staging of lung cancer, how it has evolved over the many years. So thank you very much, and I compliment you on taking up this vast topic in only 20 to 25 minutes, which were allotted to you, and you have really done a fine job. Going forward, I would like to invite our next learned speaker, Dr. Ulfat Ara, an assistant professor in the Department of Medical Oncology, again from Sher-e Kashmir, Srinagar. And she'll be talking about the molecular testing of lung cancer. It is definitely a very exciting area, and lung cancer is, I think so, one of the most dynamic of all the cancers, whereby a lot is happening in the field of molecular testing. Newer markers are definitely coming up every day. So over to you, Dr. Ulfat, please.
Thank you, sir, for your kind invitation. Can you please upload the slides because I'm not able to share the screen.
The organizers, can anyone
share the slide number 2?
Support team.
Yeah, it's visible.
Yeah, it is visible. Thank you for this kind invitation, and we'll be talking about the role of molecular biomarker testing in lung cancer. As we know, the treatment paradigm of lung cancer has really evolved with this molecular biomarker testing, and it has greatly improved the overall survival and the response rates in patients, and it has made a shift in the management of lung cancer. Next slide, please. We'll be discussing briefly about the lung cancer in India, the biomarker testing role in non-small cell lung cancer, and the evolution of the biomarker testing in non-small cell lung cancer, past and the present scenario, and the key takeaway messages. Next slide, please. As we know, the burden of lung cancer in India has been huge. As per Globocon 2020, among males, it comprises almost 5.5%, and it is the second most common malignancy among the males. And it comprises 8% of the newly detected cases of lung cancer every year. So it is a huge health burden, especially as far as malignancies are concerned, and that too in the male population. And despite the different strategies that we are using as far as lung cancer awareness programs and smoking cessation and control programs, still lung cancer is a huge health burden in the community. Next slide, please. This we had discussed about the Globocon 2020. Lung cancer comprises 5.5% of the total cases, and among males, it is the second most leading malignancy. Almost 8% of the new cases of lung cancer are detected every year. Next slide, please. This we had discussed, yes. Now we know that 50% of the patients with non-small cell lung cancer always have an underlying driver mutation. And we have now targetable agents available for a number of mutations. This has changed the treatment paradigm in the case of non-small cell lung cancer, especially for the non-squamous histology. This panel of mutation testing is advised. In squamous cell lung cancer, only in certain few cases, like the patient is very young, less than 50 years of age, or the patient is a light smoker, that is less than 10 years back history of the smoking, where you may go for this genetic mutation testing. Otherwise, for all other non-squamous, non-small cell lung cancer, we know that this driver mutation testing is advised. We know that EGFR mutations, they comprise approximately 17% of the mutations, and followed by ELK, which is 7%. EGFR exon 20 insertion, they comprise only about 4%. Rest mutations, we have that like MET, which is 3%, and compound mutations 3%, HER2 2%, ROS 2%, BRAF also 2%, and RET 2%. Then we have NTRK and PIK3, which is 1%, and MEK less than 1%. We know that now KRAS is also present in 25% of the patients who have lung cancer. There is a lot of clinical and biological heterogeneity as far as this KRAS mutation is concerned, but it is not always prognostic, although whenever it is present, it does confer a poor prognosis. And then we have patients where there are unknown oncogenic driver mutations, 31%, where we're not able to interpret what is the significance. We don't have target for each and every mutation, but we do have for number of mutations now, like EGFR, like ELK, exon, this 20 insertion mutation, EGFR, like you have amivantanab, mobocertinib. We have met exon 40 now, capmatinib, tepotinib, and selvotinib. And for HER2, we have trastuzumab, deruxtecan. For ROS1, we have crizotinib and entrectinib. BRAF also we had dabrafenib with trametinib, and for RET, selpertinib and pralsetinib. For KRAS also we have, especially for G12C mutation, sotorasib and adagrasib. ALK mutation we have this crizotinib, alectinib, and we have ceritinib, lorlatinib, and brigatinib. And for EGFR we have a host of first, second, and third generation EGFR TKIs. For NTRK fusion mutations, which are usually comprising 1% to 2%, entrectinib and larotrectinib has also come up. This is a slide which is actually demonstrating in short the various mutations which are of significance in non-small cell lung cancer and the targets which are available for their treatment. Next slide, please. We know why biomarker testing is so important in non-small cell lung cancer. It has been actually always that in the mind of clinician that to target the treatment as per the driver mutation upfront results in the median overall survival, which is substantially higher as compared to the patients who go for a non-targeted treatment upfront despite having a driver mutation, like they go with chemotherapy, and then their survival, if you compare with the patients who go upfront with the targeted treatment, is less. And this has been proven in various studies. And in this year in ASCO, there was a big article where they had compared even the outcome of patients where there was a driver mutation present, and they landed up first with chemo, and then later on they went on targeted treatment, as compared to patient subset who went with upfront targeted treatment, and the patients subset who did not go for targeted treatment at all. And the median overall survival for a subset of patients who had an underlying driver mutation and went for a targeted treatment was very high. So in this slide also the same message is there. Targeted treatment patient median OS 18 months, and with no targeted treatment 11.4 months. And also we know that even in many subset of patients where we have a driver mutation and we targeted upfront, the median OS may go as high as 40, 42 months as well. Next slide, please. These are the guidelines, various set of guidelines which we are following in our clinical practice, which recommend the routine biomarker testing. And we know right from CAP-I, SLC, AMP guideline and ASCO 2018, where limited panel testing was recommended. Now, if you go to ESMO and NCCN, and we see the number of panel testing that has really increased now in the recent years, and we have now usually EGFR, ELK, ROS, BRAF, MET, RET, NTRK, and KRAS and PD-L1 expression that has been included in the recent guidelines, because you have the targeted treatments for all these mutation panels. So this has really broadened the spectrum for treatment of our non-small cell lung cancer patients, and naturally it has improved the overall outcome of the patients as well. Next slide, please. Now, what are the various modalities of tissue molecular testing in non-small cell lung cancer? We have broadly this DNA sequencing with NGS PCR, and then we have RNA sequencing and IHC and FISH. IHC and FISH was primitive, what we initially utilized. This has still role, yes, because they are able to detect very well certain mutations like ELK and ROS1. They are very highly specialized. And sometimes we do double testing also in these patients where we have ELK and ROS1. First we do IHC and then we do FISH. But if you have a good staining with IHC, you may not require FISH as well. But NGS, which has come up in a very big way because it is a multiplex gene sequencing system, and it is being almost covering almost all the mutations. And we know that the turnover time of NGS has also decreased, and the quality control and standardization with NGS is so good. We know that DNA sequencing that can detect basically insertion, point mutations, and deletions, which are found in EGFR, RAS, BRAF, and HER2 and MET. Whereas RNA sequencing is good for detecting fusion abnormalities, like in ELK, ROS, RET, and NTRK, where we have fusion abnormalities. Next slide, please. Now we know that there's a long, time period now where this biomarker testing has really evolved from the past to the current scenario, from the techniques, the different techniques that we are using, the specimen that we are using, and the pathological interpretation. And then there are a host of tests that we are incorporating now in single panel. Turnover time has reduced, and this all has really improved accessibility to clinicians, because the turnover time, which has now hardly been 10 to 12 days or at the most 14 days, has really improved the clinicians' confidence in utilizing these panels for the upfront treatment of the patients. Next slide, please. We know that initially we used to do what? Surgical specimen, or we used to take an excision biopsy and small tissue biopsies for this tissue testing, for this molecular testing also, initially for histopathology and then for molecular testing. Now we have this FNA also, and then we have exfoliative cytology, where we are utilizing different specimens like urine, ascitic fluid, pleural fluid, sputum, and then liquid biopsy, which has evolved in a big way, because liquid biopsy is minimally invasive procedure and we can take blood and cyst fluid. Although the problem with liquid biopsy at this present scenario is that the specificity is so high, almost 96%, but the sensitivity is still low, 66%. So the liquid biopsy is minimally invasive, and in future we have usually been kept an eye especially on the liquid biopsy for monitoring over the course of time, because we know that it's not easy to convince the patient for repeated tissue biopsy or surgical specimens you can get once only. So liquid biopsy is a great role, and it will evolve over time, because you need to actually improve the standardization procedures. So we know that we utilize basically DNA this sequencing, or we do an RNA sequencing, or ultimately on the proteins. We use different technologies like PCR, cancer gene panels, MSI, whole genome sequencing, whole exome sequencing, and targeted mutations. And in RNA, we use RT-qPCR, RNA sequencing, and gene expression panels. And for protein, proteomics, and FACS. This is a slide actually depicting the advances which have really happened in the different methods and the different specimen basically that we are utilizing. We know that liquid biopsy is also accessible for the circulating tumor DNA or cell-free DNA or circulating tumor cells, whatever we are utilizing now, or even exosomes. The basic thing is that you actually require the viable tumor tissue. The viable tumor tissue, at least 50 to 100 cells you should have for histopathological examination. But for certain techniques, even you have 5% like RT-qPCR. For PCR, you require at least 30% of the viable tumor tissue. And for certain techniques, I told you RT-qPCR, you only require 5%. For NGS, require at least 20%. And this has really advanced that the requirement of tissue sample is also reduced with these new advanced techniques. Next slide, please. Now, actually, what has been the actual baseline, what we have been following is that we take first the histological specimen and we characterize whether it is squamous or whether it is non-squamous. And then for biomarker testing, what should we do? Should we take a primary tissue or should we take a metastatic lesion? But it has been found that usually primary tissue and metastatic lesion yield is almost comparable. It has been seen in EGFR, one of the studies which we will discuss subsequently also in EGFR mutation status also. If you take a primary tumor and then you take a metastatic tissue, the concordance rates of the mutation is almost comparable. It is same in primary and metastatic tissues, except that in bone biopsy tissues, we know that they get degraded easily, so they get decalcified. So you may not get a good yield of DNA from bone samples. And liquid biopsies, we know that we take a cell-free DNA in plasma. That is another option for us. Now, as far as these, we know that tests for EGFR, ELK, ROS, BRAF, NTRK, RET, and MET exon 14 skip mutation is required in all non-squamous cell, non-small cell lung cancer. And we use now broad NGS panels. And for squamous non-small cell, I told that we have to consider only in special settings like very young patients, less than 50, never smokers, light smokers, that is less than 10 pack years, or the biopsy specimen is of mixed histology, like adenoscomus and other things like that, you may consider the gene panel testing for all these mutations. Otherwise, for squamous histology, it is not required. For PD-L1 expression in all non-small cell lung cancer patients, whether it is squamous or whether it is adeno or other histologies, we know that the testing now turnover time has really reduced 10 to 14 working days, which is good for all the clinicians. Next slide, please. Circulating tumor DNA is now the latest what we are, most of the studies are undergoing are still, it's not, it has come up as a big way number of malignancies, and lung cancer is also one of the malignancies, but its role is not yet, in the first line setting to decide about the treatment. The circulating tumor DNA has not been yet standardized properly because we know there are certain, technical problems with it. The standardization of the method for circulating tumor DNA is not yet proper in all the laboratories. Then extraction of DNA and then some false positivity with the non-tumor DNA that is circulating in the circulation, that leads to some fallacies. But we know that it has really improved as far as the diagnosis part is concerned, treatment selection part is concerned. It is recommended for clinical use in advanced non-small cell lung cancer to guide the treatment under specific circumstances, but not as such, it is not, first line recommendation to start the treatment. And in resectable non-small cell lung cancer, it is not a part of current clinical recommendation, but it may be applied in this setting. It may be in the future, recommended for these patients who have undergone surgical resection for monitoring of recurrence and other things. But we know that there is definitely a role in monitoring prognosis, response to treatment, and progression and the relapse of disease. Circulating tumor DNA actually overcomes many of the challenges which are associated with tissue testing because it reflects the tumor heterogeneity and the tumor changes which are occurring over a period of time. And you don't need to take a serial biopsy because it is minimally invasive procedure. Circulating tumor DNA may never replace the tissue biopsy entirely, we know that, but it could have a complementary role to support the treatment selection in patients with non-small cell lung cancer. Next slide, please. Circulating tumor DNA may be used to detect the minimal residual disease after surgery in resectable non-small cell lung cancer. We know that because of this circulating tumor DNA, only this concept of MRD is now coming in the solid malignancy patients as well. We can now utilize this MRD concept because this is a very innovative concept, although it's not yet standardized and applicable in our clinical settings. But circulating tumor DNA testing can identify patients which are at the risk of relapse and allow for appropriate intervention. But as of now, if you detect the circulating tumor DNA, it can detect ahead of clinical progression that the patient is going to relapse. The chance is very high. But on the basis of circulating tumor DNA, it is not yet advised that you have got a positive circulating tumor DNA and MRD is positive, you'll start the treatment. The recommendation is as of now not there, but maybe in future with more advancement in the technology and more increasing, especially the sensitivity, sensitivity ratio of this technique is quite low. So it may come up as a big role in determining the treatment, especially in the patients where we are actually undergone a definitive treatment and our follow-up, especially where there is a suspicion of recurrence with this MRD positive disease. We know that there was a tracer study in which 24 early stage non-small cell lung cancer patients were followed with circulating tumor DNA as MRD for MRD testing. And they found that 93% of the patients who had disease recurrence were MRD positive, and 90% of the patients who did not have MRD positive, that is, they had MRD negative, they were without recurrence. So circulating tumor DNA profiling is able to confirm the MRD negativity and detect MRD in patients who relapse before their disease can be picked up by standard imaging procedures. So that role is very important as far as the circulating tumor DNA is concerned. Next slide, please. This is the comparison, actually a very good slide, which is very important for us because it is a good slide for comparing what is the tissue versus liquid biopsy testing. We know that tumor tissue biopsy, always it is an invasive surgical procedure. You will get this biopsy specimen, but liquid biopsy, you have to just withdraw, blood, at least 20 ml, they say in guidelines, but this is a minimally invasive procedure. Then repeat sampling, it's not that feasible and acceptable to the patient by tumor tissue testing, but for liquid biopsy, it is acceptable to the patient. And the tumor tissue, it has a very good correlation with histology and the cellular phenotype as far as tumor tissue is concerned. Direct correlation between circulating tumor DNA results with histology or cell type is never possible. So more reflective of tumor genomic landscape. Liquid biopsy is more reflective of genomic landscape, not of tumor histology, not of cellular phenotype of the underlying malignancy. We know that we require very lower tumor cell content acceptable for tumor tissue testing because the sensitivity techniques are there 1 to 10% only. But you require highly sensitive methods if you have to go for liquid biopsy because cell-free DNA may comprise less than 1% of the total circulating tumor DNA. That is why this we have already discussed, but still it's very important for us because the standardization technique for tumor tissue testing has actually we have a standardized procedures for that. But for liquid biopsy, as of now, there are no guidelines which are regarding the recommended performance characteristic of liquid biopsies. The methods have yet not been standardized properly. So evidence of clinical utility, we know that substantial evidence exists for the tumor tissue. Liquid biopsy is an evolving concept. It does not mean that in future that liquid biopsy will not improve. Maybe it improves also over time and it can be utilized complementary to the tumor tissue sampling. Next slide. This is a busy slide, but we know what is the crux of this slide. We know that when we go for the gene testing, the aim is that you get a driver mutation, which is basically targetable. Targetable mutation because targetable mutation, if you have a targetable drug, the outcome for the patient is good in terms of everything, whether you say response, whether you say survival. And in fact, the quality of life is also good if the side effects can be managed properly. And if you detect, as we know, 30% of the mutations that you detect are of no significance. So if you detect a mutation where you don't have a target, we are usually confused what to do. They are just sometimes they are of importance only in the terms of prognosis or something, but you don't have a target for that. So this slide is depicting the same thing. Next slide, please. Now we know that NGS has come up in a big way, and there are advantages of NGS. Next slide, please. There are many mutations which you go by the conventional, next slide, please, like IHC or you go by FISH. Many of the mutations we are not able to pick up. NGS is a single but multiplex gene testing. Its utility has really increased because you're able to detect a number of actionable biomarker in one setting only, and it is able to evaluate the known molecular alterations one test only. Though it seems to be costly, but if you consider it in long run, it seems to be feasible, accessible, and for the clinician also, NGS is a cornerstone now because rather than going for testing one by one and then wasting the time, NGS gives you one time test, and its turnover time has really reduced. So it detects broad range of molecular abnormalities. So NGS is now the cornerstone for all the clinicians. Next slide, please. Now we know that techniques and molecular landscapes in non-small cell lung cancer have evolved over a period of time. Starting from, we know that we have single nucleotide variant testing, which includes point mutations, small-scale deletion and insertions, and then we have copy number alterations, which include large-scale deletions and these multiple mutations and then amplifications. And we know that initially, this only single nucleotide variants could be detected with techniques like single gene assay, Sanger sequencing, pyrosequencing, then PCR, then single base extension. Now we have evolved with the techniques which can like NGS, which is able to cover both single nucleotide variants as well as the copy number variations. So this is the advantage of NGS panel, because most of the panels that we have available, they're either able to detect the single nucleotide variations or they are able to detect the copy number variation, which is not possible in one setting. So if you have to detect the whole panel, you can detect with NGS. So NGS has come up in a big way for the molecular testing of non-small cell lung cancer. Next slide, please. This is quite a busy slide, but in crux, I will tell you that it is basically depicting the various targetable mutations and their corresponding targetable drugs that are available, and still some drugs are undergoing phase 1 and phase 2 trials as well. Next slide, please. This we have discussed previously. Now, EGFR mutation testing in lung adenocarcinoma. Next slide, please. We know EGFR comprise almost 17% of the targetable mutation, and even exon 20 insertion mutations which are not targetable with EGFR TKIs, they comprise 4%. For EGFR testing, we know that we can take a fresh frozen or alcohol fixed specimens by PCR. Cytology samples are also suitable, and cell blocks are preferred over smears. And we know that there is a discordance between EGFR mutation status in primary tumors and corresponding metastatic tumors is quite rare. So this is also an advantage. You can take a metastatic tissue also for tumor testing. Next slide, please. EGFR mutation testing in early lung cancer. Next slide, please. We know that now EGFR mutation testing has really evolved, that it has come up now in the early stage as well. We know stage 1B to 3A it is recommended, because for adjuvant treatment also that EGFR TKIs, they have really improved the outcome in the patients with early stage lung cancer patients as well. So we know that it has come up in a big way. Next slide, please. Now, advantages of NGS over PCR. We know that EGFR exon 20 insertion mutation, usually it is missed by conventional PCR method, but NGS is able to detect 48.6% of the EGFR exon 20 insertion mutations via NGS as compared to PCR. So out of the 17 most common EGFR exon 20 insertion mutation variants, only 4 can be identified with PCR. This is an advantage with NGS. So targeted PCR-based approaches for detection of EGFR variants may underdetect the exon 20 insertion mutation. And we know the significance because we have a targetable drug for it, amivantamab, mobocertinib. So these patients don't respond to the EGFR TKIs. So picking up this with the NGS has led to the clinicians also their paradigm of treatment has really improved with this. Next slide, please. ALK rearrangements, we know that ALK, next slide, please. This usually we do by IHC or we do by FISH. And in most cases, IHC is 93 to 100% sensitive and specific compared to FISH. So if the staining is strong with certain proteins like D5F3 and 5A4, we don't even need to go for FISH for second testing as well. And we know what is the paradigm of patients, clinical profile of the patients of ALK positive. They're usually having these high tendency to get thromboembolic events and liver and lung, this brain mets as well. Next slide, please. ROS1 rearrangement, this has also come up in a big way. Next slide, please. We know that like ALK also, here also we go for the IHC and for the FISH testing. And we have to go for, if you get IHC positive, then you do the second testing because you want to confirm it by FISH, or vice versa also. If you get a FISH positive, then you have to go for testing by IHC as well. Next slide, please. Usually KRAS mutations, they are now comprising 25 to 30%. You will find 25 to 30% of the non-small cell lung cancer patients are harboring this mutation. And the codon 12, 13, and 61, they are the most common, but 12 is the most common. It comprises 80% of the mutations. We know, but that in more than 50% of the patients who have KRAS mutation, they have an accompanying mutation like P53, like STKL1, LKB1, or like they have other mutations as well. And we know that it is usually that the mutation, why as of now, the problem with this KRAS mutation was that the targetable drug was not available. Because a binding pocket for a targetable drug, it is very small as far as this protein is concerned. Now sotorasib is currently, and adagrasib also, we know that it has evolved, it has come up for this G1-C KRAS mutation, and this is present in 13% of the patients. So method of detection for KRAS mutation testing is actually within this NGS panel only. We know that this KRAS mutation is presenting a wide range of clinical, biological heterogeneity, but always we are not knowing what is its prognostic significance. But most of the cases that KRAS, when it is present, it is mutually exclusive with other mutations, and it is of poor prognosis. That means if patients have KRAS, they usually don't have EGFR, ALK, and other mutations. And we know the other thing with this KRAS is that if KRAS is present and TP53 is present, it detects that the patient can respond to immunotherapy. Next slide, please. BRAF mutations is actually present in hardly 1 to 2% of the lung cancer patients. And among all the BRAF mutations, V600E mutation comprises more than 50% of the mutations. And other non-BRAF mutations, they are present in 17% of the patients. Overall, not more than 1 to 5% of the patients of non-small cell lung cancer harbor this mutation, and NGS is the panel which is recommended in the patients. We know that there is a downline stream mechanism of getting resistance in these patients with MEK, so we combine dabrafenib with MEK inhibitors, and that this is to overcome the resistance pattern. And resistance generally develops via pathways that bypass the RAF. Next slide, please. MET, we know MET has basically amplification and then exon 14 skip mutations. And both are present for, skip mutations. We have targets like capmatinib, tepotinib, and savolitinib. And for amplification, we have bispecific antibodies like desilostimab and amivantamab. And we know that 3 to 4% of non-squamous non-small cell lung cancer harbor it. And it is the sarcomatide histology which mainly harbors MET exon 14 skip mutation. 20 to 30% of the sarcomatide histology does. And we know that DNA NGS can be done, but increased sensitivity is with the RNA NGS for testing of MET exon 14 skip mutation. Next slide, please. We know that IHC and FISH not recommended at all. You can do DNA based PCR, but it is design dependent, and then RNA, we have certain technical consideration. Best method to do for this MET exon 14 is basically NGS, and that too RNA NGS. Next slide, please. RET, we know that RET mutations are also present 1 to 2% of non-squamous cell, and in papillary thyroid cancer, we know that 10 to 20% are present. And basically, it gives rise to a cytosolic protein, which has an active tyrosine kinase domain. And majority of RET fusions can be detected by DNA NGS, and increased sensitivity is with the RNA NGS. Next slide, please. We know that for RET fusion detection also, RNA NGS is the method of choice. Next slide, please. For NTRK fusion detection, we know that again, RNA NGS is the most suitable test, and we have now the targetable drugs also available, larotrectinib and entrectinib. Next slide, please. We know that the detection method is again NGS, and there is a potential for multiplex testing, less depletion of tissue, and fusion partner can be detected. Next slide, please. HER2 mutations, we know that for HER2 we have amplification, overexpression, and mutation. Mutations are present in 3 to 5%, and mostly exon 20 insertions are present. They're exclusive with other mutations present in never smokers, and worse overall survival in lung cancer mutation consortium. We know targetable drugs like trastuzumab deruxtecan is available, and IHC is used to assess the HER2 expression. Overexpression, as we do in breast also, it is seen in 59% of the non-small cell lung cancers. Next slide, please. This is the 2022 treatment paradigm shift based upon the molecular biomarker positive testing, what we have previously discussed. Next slide, please. PD-L1 overexpression in non-small cell lung cancer. This is again, we know that the cornerstone for PD-L1 expression testing is IHC. Next slide, please. We know that TMB, tumor mutation burden, was also utilized, but it has not been found to have that much correlation. It was found in a number of studies to study the response to the immunotherapy, but it was not found to have a high correlation. MSI, MMR testing, we also know that this is not that much advised in lung cancer, though MSI high patients have this high tumor mutation burden, but vice versa does not exist. Tumor mutation burden basically detects the quantum of the somatic mutation burden in a tumor, so its correlation in lung cancer is not that high. We know that we use different platforms like DACO, Ventana platforms to detect, and different antibodies 22C3, SP263, SP142, and 288 for different immunochemotherapy agents like Pembro, Durva, Atizo, and nivolumab. Next slide, please. These are the different antibodies that we are utilizing for PD-L1 testing. Next slide, please. And the biomarker for immunotherapy in non-small cell cancer, it is always a controversial topic. We know that PD-L1 is the sole current biomarker able to guide immunotherapy in lung cancer. It's still not a perfect, because it does not mean that if your patient is PD-L1 negative, the patient will not respond. Tumor mutation burden, as I previously discussed, it was previously studied in a number of studies, but its correlation with survival, with response is still very poor, and MSI role in lung cancer is very less. And I told you the MSI high correlation is with TMB high, but vice versa is not there. LAG3, it is possibly related to resistance to immunotherapy. It is still undergoing studies. Next slide, please. Conclusion is that the biomarker testing in non-small cell lung cancer has evolved from a single gene to multiplex testing based upon NGS. Multidisciplinary meetings help in better understanding. Sample should contain adequate tumor content, at least 10%. Tumor turnaround time is very less now, 10 to 14 days, and NGS is the standard. Thank you very much. Thank you.
Thank you very much, Dr. Ulfat, for taking us through the very exciting and very exhaustive means testing methodologies for lung cancer. That's what makes lung cancer one of the most exciting cancers to treat nowadays. Earlier it was breast cancer, but now I think so it is lung cancer. Lot of options are there, lot of avenues of treatment are there. So thank you very much, Dr. Ulfat. An excellent talk. The next topic, I think so, Dr. Ankur is not here. The next topic was to be presented by Dr. Ankur, but I think so he's
Maybe
stuck.
Ankur sir is there, sir.
Oh, okay, he's there. So, Dr.
Hi, good
Ankur,
evening, sir.
presenting now, or I
If you are
got the
ready,
message.
sir, you can present. I just need a minute.
Okay. So, with the permission of the organizers, I think so I can prepone my talk, and Dr. Ankur can present his talk after my talk. Is it okay, the organizers?
No issue, sir. Please.
Yeah. So, I would be speaking on ADORA trial. So now, once Dr. Syed has given us a nice overview on lung cancer, and Dr. Ulfat has taken us through how to actually test for the various biomarkers in lung cancer. So now let us move on to a more niche topic of EGFR mutant non-small cell lung cancer. And we all know that osimertinib has proved its mettle in this field in the metastatic setting, and also in the adjuvant setting. Let us see means what the data says for the role of osimertinib. So next slide, please. So, 1 in 3 patients with non-small cell lung cancers present with resectable disease. Amongst this, approximately resectable lung cancers comprise about stage 1B, stage 2, and stage 3A lung cancers. So it's about 30% of the patients are there. Next slide, please. So, even though the patients present at an early stage, even in the earliest stage, stage 1B, there are still a 45% chance of recurrence at 5 years. So that is not good. In stage 2, it increases to 62%, and in stage 3, it increases to 76%. So there is a lot of scope for improvement of the adjuvant therapy, looking at the rates of the recurrences even in the completely resectable stages of lung cancer. Next slide, please. So, as I had told previously also, we Asians have a higher percentage of the EGFR mutation ranging to about 30 to 40%. And it is evenly distributed amongst all the stages of lung cancer, stage 1, 2, 3, 4. The percentage remains the same. So the concept is, if EGFR TKIs were available in the resectable setting, a similar proportion of patients may be able to benefit from it compared to the advanced setting. Next slide, please. So to test this concept, osimertinib was given as an adjuvant therapy in patients with stage 1B, 2, 3A, EGFR mutation positive lung cancer after complete tumor resection. This was the ADORA trial. The principal investigator was Herbst et al. And it was a multi-center study. Next slide, please. So this was a phase 3 double-blind study. And the key inclusion criteria we will study in the next slide also, but this is the flow of the trial. All patients with stage 1B, stage 2, and stage 3A completely resectable lung cancers were taken in this trial. with or without adjuvant chemotherapy. They were stratified as per the stage and also the type of the EGFR mutation, and obviously Asian versus non-Asian race. They were randomized in a 1:1 fashion to osimertinib 80 milligram once daily, which is the experimental arm, versus placebo once daily. And the planned treatment duration was 3 years. And the primary endpoint of this trial was the disease-free survival. And the secondary endpoint was the disease-free survival in the overall population, and the overall survival data, and the safety analysis, and the health-related quality of life. Next slide, please. So this is the inclusion and the exclusion criteria in a little bit of more of detail. Here, patients were basically a primary non-squamous non-small cell lung cancer, post-operatively staged as stage 1B, stage 2, or stage 3A. They all had a central confirmation of EGFR exon 19 deletion or L858R EGFR mutation. Patients were allowed standard post-operative adjuvant chemotherapy consisting of a 4 cycles maximum of platinum-based doublet chemotherapy. The chemotherapy was allowed, but it was not mandatory. So there were certain population of patients who were not given chemotherapy also. However, a complete surgical resection of the lung tumor was mandatory, and recovery from the resection surgery and treatment was to start no earlier than 4 weeks following surgery. An MRI or a CT scan of the brain was done to map the brain prior to the surgery, and obviously the PS was 0 to 1. The main exclusion criteria in this trial, this is what we have to apply in our clinical practice also, that patients were not supposed to receive any pre or post-operative radiotherapy or any neoadjuvant chemotherapy or any previous EGFR TKI exposure was also not allowed. Patients who had only segmentectomies or incomplete surgeries or wedge resections were not allowed. So these were the key inclusion and the exclusion criteria of the ADAURA trial. Pretty strict the criteria were there. Next slide, please. So this was the baseline demographic of the trial. 1:1 allocation to osimertinib versus placebo, and here we can see the stratification. I mean, as far as the staging is concerned, stage 1B had around 32% patients, 33% patients, and 35% patients in stage 3 and 3B. So it was a stage upgradation was done in the 8th edition of the AJCC, and there also there was not much change in the stratification as far as the staging was concerned. Next slide, please. So this was the disease-free survival Kaplan-Meier analysis. This was the first primary analysis in the stage 2 and stage 3A patients. Now look at the curve. So the blue curve represents osimertinib, and the yellow curve represents the placebo after the surgery. And here we can see there was a marked improvement in the disease-free survival with osimertinib at 65.8 months versus placebo at 21.9 months with a robust hazard ratio of 0.23. Next slide, please. So in the overall population, so now if we are taking the stage 1B population also into the picture, here also we can see that the osimertinib had a 65.8 months DFS versus placebo at 28.1 months DFS. The hazard ratio again is extremely robust at 0.27. So approximately 73% improvement in the disease-free survival when we gave osimertinib for 3 years vis-a-vis placebo. Next slide, please. So the 4-year disease-free survival was consistent across the various disease stages. In stage 1B, we can see that the osimertinib had disease-free survival 4-year DFS of 80% versus 59% for placebo. As the stage increases, the gap between the osimertinib and the placebo also increases. For stage 2, it was 74% DFS versus 42%. And in the stage 3A, it was 65% DFS versus 14% DFS with a hazard ratio of 0.20. So it is very much logical that as the stage increases, so is our conviction of giving osimertinib in such a population. Next slide, please. So this is the forest plot analysis of the ADORA trial across various stratifications, pre-planned stratification groups. And here we can see there is hardly anything to contest here, that in all the subgroups, irrespective of the age, sex, smoking history, EGFR mutational status, presence or absence of adjuvant chemotherapy, osimertinib had a very high and robust hazard ratio vis-a-vis placebo. Next slide, please. So this is an early snapshot of the overall survival of patients in stage 2 and stage 3A patients. Obviously, it is an early analysis at 2 years. So means for osimertinib also it was not reached, and for placebo also it was not reached. But we are seeing some separation of curves at 2 years data. And the patients and investigators remain blinded to the treatment in order to facilitate the assessment of OS at maturity. So further data is expected down the line also for as far as overall survival is concerned. Next slide, please. So this is not a new concept of starting EGFR TKIs in the adjuvant therapy. In the adjuvant setting, we have got one select trial which was conducted with erlotinib after adjuvant chemotherapy, which showed an improvement in the disease-free survival of 88% versus 76%. The Radiant trial was also conducted, erlotinib versus placebo after adjuvant chemotherapy, and there was a meaningful improvement in the DFS by approximately 16 months when we used erlotinib versus placebo. The IVAN trial, again with erlotinib, again showing a doubling of the DFS of erlotinib versus adjuvant chemotherapy. We have got an adjuvant geftinib trial also, and the BR19 trial with geftinib. So most of the trial was showing a significant DFS improvement, but as we can see, there was no significant OS improvement in the geftinib adjuvant trial. So here also in the ADORA trial also, we have seen a remarkable improvement in the DFS. The OS data is yet to mature. Let us see means what comes in the subsequent years. Next slide, please. So the type of recurrence is a very key consideration in the resected non-small cell lung cancer. Local or regional recurrence is generally associated with a longer post recurrence survival than distant recurrences. And definitely we know that a patient who has recurred in the brain definitely has a markedly lower survival as compared to a non-CNS metastasis. And we also know that osimertinib has got a very good exposure in the brain because of a very good BBB permeability. And in the advanced NSCLC setting, it has been time and again proven that osimertinib definitely has a higher CNS free period as compared to other TKIs, as compared to chemotherapy, etc. Next slide, please. So let us see what happens to the patients on osimertinib versus placebo. So in the osimertinib trial here, if we can see in this left hand side bar diagram, 11% patients recurred. So 11% patients had a DFS event, and if we dissect these 11% patients further, 62% patients had a loco-regional recurrence and 38% patients had a distant recurrence. So let us now compare what happens to the placebo arm. In the placebo arm, there were 46% DFS events. So if we dissect out the 46% further, 39% patients had a loco-regional recurrence and 61% patients had a distant recurrence. And as mentioned earlier, these 61% patients with distant recurrences will definitely have a worse DFS and OS as compared to a person who is having a loco-regional recurrence. So somehow osimertinib is able to prevent or decrease the incidence of distant metastasis, more specifically CNS metastasis. Next slide, please. So these are the sites of disease recurrence, again dissecting it further. So the blue bars are the osimertinib and the yellow bars are the placebo. 12% lung, 6% lymph nodes, 6% CNS with osimertinib, and vis-a-vis if we compare 26% lung, 17% lymph nodes, and 11% CNS. So these are the breakup of the various distant metastatic sites which have occurred with osimertinib versus placebo. So definitely the placebo arm has a higher incidence of distant metastasis, especially the CNS and the contralateral lung and various lymph nodes, etc. Next slide, please. So let us now again see what is the updated CNS disease-free survival events in stage 2 and 3A. Here we can see as expected with osimertinib, there is almost only 1 or 2% or at 4 years, only 10% incidence of CNS events. Vis-a-vis in the placebo arm, definitely there's a 25% incidence of CNS events with placebo. So definitely it is there's a significant difference as far as the CNS control is concerned with osimertinib. Next slide, please. So coming to the safety summary, I need not mention it because osimertinib I find as one of the safest TKIs to administer. Not much of a side effect profile which troubles the patient or the treating physician, and not much of serious adverse events leading to death, not much of adverse events leading to discontinuation. So pretty well tolerated drug. Next slide, please. So all causality adverse events in greater than 10% of patients is pretty well manageable with diarrhea, paronychia, definitely more. But again, I would say much better than any other TKIs which we have used. Next slide, please. So this was another analysis from the ADAURA trial, which was done by Wu et al. And this was basically a more detailed analysis of what was the outcome with osimertinib when postoperative chemotherapy was given or not given. Next slide, please. So adjuvant chemotherapy use, about 60% of the patients in the ADAURA trial received adjuvant chemotherapy for a median duration of 4 cycles. And so approximately as expected in stage B, 1B, 26% received adjuvant chemotherapy. In stage 2, 71% patients received chemotherapy. Stage 3A, 80% patients received chemotherapy. Next slide, please. So if we can see, in patients who had been given adjuvant chemotherapy, if we are giving osimertinib versus placebo, there is a very good separation of curves, as was mentioned in the overall survival, means in the overall patient population, which I had earlier mentioned. Even in patients without adjuvant chemotherapy, that's a comparatively smaller population of patients, there also, if we give osimertinib versus placebo, definitely there is an advantage with osimertinib. Next slide, please. So this is the forest plot analysis with adjuvant chemotherapy, without adjuvant chemotherapy, and here we can see that whether if we give adjuvant chemotherapy followed by osimertinib, or if we don't give adjuvant chemotherapy, still the overall the DFS analysis remains the same and in favor of osimertinib. So giving us a pointer that the adjuvant chemotherapy may be decided based on the stage at surgery, but it will not impact whether to give osimertinib or not to give it, because osimertinib will favor both the population of patients. Next slide, please. So here also we can see that a DFS in patients with or without adjuvant chemotherapy for stage 1B, definitely osimertinib is favoring. Next slide, please. Again, in stage 2 patients also, DFS with adjuvant chemotherapy, without adjuvant, definitely osimertinib is favoring in both the subsets versus placebo. Next slide, please. And in stage 3A, again, the same story is repeated. Whether we give adjuvant chemotherapy, whether the adjuvant chemotherapy is demanded by the stage, but whenever we give osimertinib, definitely it will favor more vis-a-vis the placebo. Next slide, please. So now let us come to another analysis of the ADAURA trial of the patient-reported outcomes from ADAURA. Whenever we give an adjuvant therapy, the most important thing which is there is that the drug in the adjuvant therapy should be well tolerated. We should not give too much of side effects from the adjuvant therapy. So this trial, this analysis was done by Mojem et al. And this was the patient-reported outcomes from ADAURA. Next slide, please. So the health-related quality of life methods which were used was the SF36 survey, and the data collection was done at initial and at randomization at week 12, at week 24, and every 24 weeks thereafter. Next slide, please. So here we can see that over time, the compliance rate with the SF36 health survey was high in both the osimertinib and the placebo arms. Next slide, please. The time to deterioration of physical and mental components again was pretty much similar for osimertinib versus placebo. So osimertinib did not lead to any major physical impact or mental impact on patients who have been taking it for a period of the mandatory period of 3 years. Next slide, please. So let us now come to the summary of the three different analyses of the ADAURA trial, which I presented just now in the past few minutes. So in this updated analysis of osimertinib versus placebo, patients have been followed for a further 2 years, and all had the opportunity to complete 3 years of planned study treatment. So overall, there was a 77% reduction in the risk of death or recurrence with adjuvant osimertinib versus placebo, with a hazard ratio of 0.23. The median DFS stood at 65.8 months with osimertinib versus 21.9 months in the placebo arm. There was also a 73% reduction in the risk of death or recurrence with adjuvant osimertinib in the overall population also. An improvement in the DFS was seen regardless of whether the patients received any adjuvant chemotherapy or not. The DFS benefit was consistent across the various stages. That means the AJCC 7th edition staging versus the 8th edition staging. It did not make much of a difference. Osimertinib led to a clinically meaningful improvement in the CNS disease-free survival because of a high penetrability in the brain. The safety profile of osimertinib was consistent with the established safety profile of osimertinib. It was consistent, and no new safety concerns appeared in the adjuvant analysis. And the median total duration of exposure to osimertinib was 35.8 months. So imagine, so the mandatory is 36 months, and the median total duration of exposure was 35.8 months. So almost nearly no dropout was observed with osimertinib. So with these positive results, these updated data reinforce adjuvant osimertinib as the standard of care for patients with EGFR mutant stage 1B, 2, 3A, NSCLC after complete tumor resection with or without adjuvant chemotherapy for a period of 3 years. So next slide, please. I think so. With that, I would like to end my presentation, and thank you very much for a patient hearing. So, Dr. Ankur, if you're ready,
Yes, sir, I am
introduce.
ready. Huh?
Yeah, fine. So after the encouraging adjuvant data, I would like to introduce Dr. Ankur Varshney. He's a senior consultant at Medanta Hospital, Gurugram, and he would be taking us through the practice of osimertinib in EGFR mutant metastatic NSCLCs, the decoding the treatment options for EGFR mutant NSCLCs. Over to you, Dr. Ankur Varshney, for your talk.
Thank you, sir. And Abram, can you move my slides? Hello.
Technical support, kindly run the slide number 3, please.
Thank you, Rajesh sir, for your comforting words. And as you have already highlighted the treatment of early lung cancers, now we move to the more advanced disease, metastatic disease, which we see quite commonly in our scenario. And with the number of EGFR drugs available, we will discuss which EGFR treatment is best. So next slide, please. So before going to the treatment part, we will start what is the burden of the disease. And as per the Globocon 2020 data, the lung cancer is one of the leading cancers as per the new cases registered. And if we see the deaths due to the cancer, then lung cancer is the topmost cancer which cause the leading mortality in patients of cancer. Next, please. So in both the sexes combined, the lung cancer is the second most common diagnosed cancer, corresponding to 11.4% of total cases, while it is the leading cause of cancer death, approximately 18% of total cancer deaths. Next slide. So what are the parameters which decides our choice of first-line treatment in a patient with advanced non-small cell lung cancer? And the desired treatment parts which we study in various trials include progression-free survival, overall response rates, presence of brain mets, as brain mets are quite evident in all stages of lung cancers, safety and toxicity of the drug, and what are the effect of this drug on the quality of the life of the patients, and if patient is having a subsequent therapy upon progression, and what are the therapies. So next slide, please. Next slide, please. So we see that there are three generations of tyrosine kinase inhibitors. And the first generation was used Geftinib, as shown in the IMPASS study, which have shown a median PFS of 9.5 months. The Ilotinib in the optimal study has shown a median PFS of 13.1 months. The second generation TKIs, which includes Afatinib, has shown its efficacy in the Lux lung trial, and it has shown a median PFS of 11 months. While Decomitinib, second generation TKI, in an Archer study, has shown a median PFS benefit of 14.7 months. But we have seen maximum benefit of PFS with the use of third generation tyrosine kinase inhibitor, and this includes Osimertinib, which has shown a median PFS of 18.9 months in the Flora study. So direct comparison in the with these TKIs is not possible, and most of the slides includes indirect comparison of these trials. Next slide. And if we see the difference between progression-free survival on the indirect comparison, then we see in the Lux 7 studies, where the median PFS with the use of in the Geftinib arm was 10.7 months, 10.9 months, while in the Afatinib arm it was 11 months. The trial included patients with the brain mets. If we see the Archer studies, the brain mets were not included. In the test arm, the Decotinib showed a median PFS of 14.7 months, while in the comparative arm, the Geftinib showed a median PFS of 9.2 months. In the Flora study, we see that the Osimertinib has shown a significant PFS benefit of 18.9 months, and versus the comparator, which was only showing a PFS benefit of 10.2 months. In the Flora trial, brain mets were already included. And if we compare all these charts, we see that there is a crossover in the Kaplan-Meier curves, which in the Lux trial, the crossover occurs at 12 months. In Archer trial, the crossover occurs at 6 months. While if we see the Flora study, then there is an immediate separation of these curves, and this separation is maintained at the interval, a prolonged interval, and this duration of response is maintained with the use of this drug. Next slide. So we see early separation of PFS curve is shown with the use of osimertinib only. Next. So we study the now after PFS, we see the overall response rates, and in the Lux trial, the overall response rates with the use of afatinib, it was 70%, while with the ergatinib, it was 56%. Median duration of response with the afatinib, it was 10.1 months. With the median duration of response with the geftinib, we see it was 8.4 months. When we see this as compared to the Archer study, the overall response rate with the use of decomitinib was 75%. With the use of eftinib, it was 72%. So there was not much difference in the overall response rates. While median duration of response, if we see, then decomitinib has a median duration of response of 14.8 months as compared to geftinib, which has showed a median duration of response only 8.3 months. When we come to the FLORA study, with the use of osimertinib, response rates were 80%, while the TKI comparator arm response rates were 76%. Well, if we study the duration of response, then duration of response with the use of osimertinib, it was 17.2 months, while with in the EGFR TKI comparator arm, it was only 8.5 months. So we see the duration of response is at most doubled with the use of osimertinib in the FLORA study. Next slide. Osimertinib has shown in amongst all the 3th-generation TKIs as the highest overall response rate and median duration of response. Next slide, please. So if we see the data of overall survival, then we see that osimertinib is the only drug which have been shown the benefit of overall survival, and with the median overall survival in the arm was 38.6 months, and while the in comparator arm, it was 31.8 months. So it has a significant p-value of 0.04. Median OS is, we found that median OS is greater than 3 years, and patients who have osimertinib were likely to be alive at the 2nd and 3rd years. So if we see the Kaplan-Meier curves, the difference in the OS survival has maintained. At the end of 3 years, approximately 54% of patients in the osimertinib arm was surviving, while in the comparative arm, it was only 44% of the patient who has survived. Next slide, please. So if we see this data in the Lux trial and the Archer trial, so in the Lux trial, the median OS benefit with the use of afatinib was only 27.9 months versus 24 months with the use of geftinib. The difference was not found to have a statistical significance. While we see in the Archer study, so there is some statistical issues. We see that they have used a hierarchical gatekeeping procedure and have shown a PFS benefit, which was greater than the overall response rate. And this difference was found to be more significant than overall survival. So we will discuss this in detail in the next slides. Next slide, please. So this was a critical analysis that was done, and this showed that in phase 3 Archer trial, which had already excluded brain mets, it showed a numerical improvement in OS of 34.1 months with the use of decomitinib versus 26.8 months for geftinib. And if we see this difference, then this significantly this statistical analysis has use a hierarchical stratified statistical design, and it does not meet significance in overall response rate. Thus, overall survival data cannot be analyzed in this trial. Next slide, please. With the use of osimertinib, the main thing is the continuation of therapy. Approximately 28% of the patients were still receiving osimertinib at the end of 36 months. And as compared to the comparative arm, if we see that there were only 9% of patients who were continuing the same therapy. Next slide, please. The important, one of the most important topic, as we already discussed, is the CNS involvement in the disease. And if we see the data of the osimertinib, it has shown a superior systemic PFS benefit regardless of CNS disease at the baseline. If we see the data of the patients who have known CNS mets or who have treated brain mets, there were 116 patients. And with the use of osimertinib, the median PFS in this cohort was 15.2 months, while in the standard cohort patients, it was only 9.6 months, and this difference is found to be statistically significant. In the patients who doesn't have CNS match, there were 440 patients, and in this cohort, the median OPS benefit of osimertinib was found to be 19.1 months, and with the use of standard arm, which was erlotinib, it was the median PFS was only 10.9 months. So this difference is again found to be statistically significant. We see at the in the study, CNS progression events were in the 6% of patient population who were receiving osimertinib, as compared to the 15% of patient population who were using in the control arm. So osimertinib has a strong CNS activity, and this can useful for the patients who have brain mets, and in patients who doesn't have brain mets, CNS disease is already slowed down with the use of osimertinib. Next slide, please. If we see the intracranial PFS with the use of osimertinib, then we see that the median CNS PFS was not recorded in the patients with the use of osimertinib, while in standard of care patients, this median CNS PFS was 13.9 months. And median follow-up of the patient, if we include and the use of osimertinib, this was 12.4 months, while in the standard of our care patient, it was only 7 months. So we conclude that CNS PFS was statistically significant with the use of osimertinib versus the control arm. Next slide, please. So now this is a slide which is comparing the all baseline data in comparison to the CNS response. And if we see the afatinib study, then we have the patients in the test arm, which were having 81 patients of asymptomatic brain mets. And they have, in the control arm with the use of afatinib, they have 51 patients. The response rates with the use of afatinib were reported, and better response rate, while in the control arm, the response rate with the use of afatinib was not reported. If we see median CNS PFS, it was 8.2 versus 5.4 months, while in the control arm, it was only 7.2 versus 7.4 months. So if we study the data of decomitinib, then this study does not include any brain mets patient, and the brain mets patient were excluded from this study. So if we see the FLORA data, then we have baseline asymptomatic CNS mets in 116 patients in the osimertinib control arm, while baseline asymptomatic CNS mets determined with neurological response central independent committee, it was only 128 patients. If we see the response of this data, then we have already seen that the median CNS PFS was 15.2 months in the osimertinib cohort, while it was only 9.6 months in the PFS arm. And if we see the duration of response, then it was not recorded in the osimertinib arm, while it was only 13.9 months in the control arm. All these differences were found to be statistically significant. Next slide, please. Now, important aspect of every drug is a safety. And if we analyze the drug data, we used to analyze the grade 3, 4, 5 adverse events. So if we see the grade 3, 4, 5 adverse event of the Archer study, we see that dermatitis was present in approximately 14% of the patient, and it was usually grade 3 or grade 4 in the use of decomitinib. Diarrhea was present in 8% of the patient with the use of decomitinib. While if we compare with the use of control arm, then with the use of afatinib, no patient has grade 3 or 4 dermatitis, while 1% patient have diarrhea. If we see the study of this dermatitis, then approximately 4% of the patients have maculopapular rash, approximately 4% have pustular rash, and another 4% have one more rash. So we see that approximately grade 3 or 4 adverse event with decomitinib were reported in approximately 60% patients in the Archer study. While if we see greater than grade 3 adverse event with the afatinib, it was reported in 31% of the patient in the Lux trial. If we see the FLORA data, then grade 3 or 4 adverse events were reported in less than 2% of patient population. Diarrhea was present in only 2.2% of patient population. And we see the control arm, the difference was not found to be significant. In the control arm, the diarrhea was also present in approximately 2% of patient population. If we study the fatigue was present in both the control and the osimertinib arm, 1.4%. And if we see the data of rash, then rash was further lower down with the use of osimertinib, and it was higher in patients who have used the EGFR TKI comparator. So we see that grade 3 adverse events were reported of approximately 18% of patient population in the FLORAS trial, and majority of these side effects were quite comparable in the EGFR TKI comparator arm. Next slide, please. So comparing each drugs with the specific side effects. So with the use of afatinib, skin side effects were reported in 9% of patient populations. Nail changes were present in 2% of patient population. 13% had diarrhea, and stomatitis was present in approximately 4% of patient population. With the use of decomitinib, it has a significant skin toxicity found in 14% of patient population. Nail changes were again higher with 7% of patient population. Diarrhea was significant in 8% of patient population, and stomatitis was found in approximately 4% of patient population. While in FLORA trial, where osimertinib was used, skin and nail changes were present in then less than 1% of patient population. Diarrhea was found in 2% of patient population, but it was also the same rate is seen in the comparative arm. And in stomatitis, only 1% of patient population had developed stomatitis. Next slide, please. So after the toxicity, there is a concept of dose reduction, and how many dose reductions are required to have a comparable quality of life. We study that in Lux trial, the adverse events leading to dose reduction of the afatinib was found more frequent, and approximately 41% of the patient population has dose reduction as compared to the comparative arm, where only 2% of patient population needed a dose reduction. In Archer study, the data is more significant with the use of decomitinib, where approximately 67% of patients require dose reduction because of adverse event, while as compared to the standard of care geftinib, it was only 8% of the patient population who requires a dose reduction. In the FLORA study, if we see the frequency of dose reduction because of adverse event, then in the osimertinib cohort, it was only 5%, while standard of care in a EGFR TKI comparative arm, it was only 4%. So we see this difference because of intolerance side effects is quite significant, and osimertinib has shown a better tolerance among all the side effects. Next slide, please. The most important factor which we study these days is the quality of life. And if we see with the Archer study, the quality of life they report with despite the side effects and dose reductions, quality of life was maintained. But the FLORA trial reported that quality of life was improved from baseline in both the EGFR in both the cohorts, with no clinically relevant differences between the groups. So we have a drug which has shown a better safety profile, requires less interruption of dose reduction, and quality of life has been improved with the control of the disease. Next slide, please. So we had to see that approximately 1/3 of patients who have EGFR mutate and treated with first and second generation EGFR TKIs are able to receive second line osimertinib. In a study which has shown that approximately 10 patients who are EGFR mutation and is started on a first generation or second generation TKIs, approximately 73 to 77% patient had to receive second line of therapy due to disease progression, or some of these patients developed T790 mutation. So among these 70% patients, approximately only 60% received a valid T790 mutation results. Sometimes tissue is lost, or patient is lost to follow up, and they are not agreeing to get this testing done. So approximately 60% of patients who underwent this testing, T790M testing, approximately 50% of them had we have found that T790M mutation is positive. And approximately 50% of these patients are the only persons who had to be treated with the use of osimertinib, as this is the only drug which have been found to be effective against this mutation. So 7 out of the 10 patients who start on first, second generation TKIs will not be able to receive osimertinib in second line because it is not able to predict who will develop T790M mutation resistance. Next slide, please. So we see access to second line, then approximately 1/3 of the patients do not have access to the second line treatment. If we see the data of IMPASS study, and subsequent treatment was found in around 76% patient, then further study shows that subsequent treatment is received in 72% of patient population in NEG study. In Eurotech study, subsequent treatment was found given to 68% of patients. In optimal study, only 63% of patients received the second line treatment. In Lux trials, approximately 57% of the patients received the second line treatment. So approximately 2/3 of the patients receive second line treatment, and 1/3 of the patients are not have access to the second line treatment in the earlier arms. Next slide, please. So what is the real world evidence of T790M after the use of earlier TKI inhibitors, which is the afatinib? A Japanese study shows that 43% of the 37 patients acquired T790M mutation after the use of first line afatinib. In a Taiwanese study, approximately 48% of the patients who were rebiopsied after their progression on lung disease after afatinib had shown T790M mutation positive. In another Taiwanese study, approximately 28 patients who were treated with afatinib, T790M mutation was found in approximately 32% of patient population after disease progression. Next slide. So less than 50% patients who have been on afatinib therapy acquired T790M mutations and further led to disease progression. Next slide, please. So sequencing of EGFR TKIs is must, and in patients who have received prior generation TKIs and then who patients develop T790 mutations can be treated with osimertinib, but this is not an optimal critical care because majority of patients who are not getting tested for T790 mutation, not everyone with the disease progression, their performance test goes down and they are not able to have the additional treatment and subsequent therapies. Tissue and liquid biopsies are not always successful. Many a time tissues are lost. And we have seen that osimertinib is the only drug who have shown a significant overall survival benefit, which none other TKI have shown as a first-line therapy. Next slide, please. So what are the factors which we require in sequencing? And the very first important factors is toxicity to the drugs. We have already seen the cytotoxic side effects with the use of tecometinib and afatinib. There is occurrence of T790M mutation. We have already studied that with the use of afatinib, approximately 50% patient develop this T790M mutation. And sites of progression, this is quite important because sites of progression is only CNS, and majority of the earlier TKIs doesn't have CNS penetrations. Then there is the concurrent morbidities which restricts the use of therapy, and then this is the patient choice who decides what TKI he will like to opt for. Next slide, please. Next slide. So what are the real world studies with the use of first line osimertinib? We are going to study the next some few studies. Next slide, please. Next slide. So this is a flower study, which is a retrospective observational study done in Italy. And in this, the patients were having first-line metastatic advanced EGFR and SCLC. Baseline treatments were not allowed. Median age in this patient study was 68 years. Majority of these patients have adenocarcinoma. Performance status was preserved in some majority of the patients, and only 13% of the patients have a PS greater than 2. Brain mets were allowed. Majority of the patients have comorbidities. Approximately 94% have comorbidities. If we see the baseline EGFR status, we see majority of the patients have exon 19 deletion, which was followed by exon 21 L858R mutation. So if we see this data, then we see that median PFS in this cohort was 18.9 months. Median PFS in patients who were diagnosed with brain mets was 13.3 months, and median PFS in patients who were diagnosed to have without any symptom, it was 15.5 months. So the partial response was reported in 73% of patient population, and stable disease were reported in 23% of patient population. Next slide, please. So in the most common adverse events that were reported were diarrhea, recorded in approximately 38% of patient population. And if we see, then majority of this was only grade 1 and grade 2, and grade 3 and grade 4 diarrhea was present on only 3% of patient population. Venous thromboembolism was diagnosed in approximately 10% of patient population, and approximately 8% of patient population, it was found to be grade 3 and 4. So most common side effect was diarrhea, followed by skin rash and paronychia. But most severe side effect was found to be have venous thromboembolism, and no difference in the rates of venous thromboembolism was reported according to age, performance status, comorbidities, and tumor load. And difference in the survival outcome was not affected with the age, comorbidity, and type of EGFR mutation. So we see that osimertinib confirms effectiveness and safety in the real world, though we have a thromboembolism which was quite frequent in the real world scenario noted down. Next slide, please. In the OSIFACT study, which was done in Japan, again, we had a median age of patients like 71 years. Majority of patients with adenocarcinoma. Patients with poor performance status were included. Patients with brain mets were included. And they were also stratified with the use of PDL1. So if we see overall response rates, the overall response rate in this study was found to be 76%. The median PFS in the study was found to be 20.6 months in the patients, and median PFS with this was found to be significant irrespective of the PDL1 percentage. Next slide, please. If we see the safety analysis of this study, then majority of the patients, there was they found that significant side effect of pneumonitis, which was found in 12% of patient population. Grade 3 adverse event was found in 4.5% of adverse event, and they also reported grade 3 non-hematologic toxicity with the use of QTC interval prolongation. The majority of the side effects, majority of the reason for discontinuation of the therapy was disease progression, and approximately 25% had a side effect on pneumonitis, which they decided to quit the drug. Approximately 16% have other adverse events, and they decided to quit the drug. So in this study, pneumonitis was reported as a higher as compared to the FLORA study, though the study incorporated the same that the PFS and OS benefit is there. It raised another concern of a side effect, which was pneumonitis. Next slide, please. In Mykonos studies, which was done in a multinational, which includes USA, Japan, Germany, and China, we see the median age of the cohort was 70 years. Majority of the patients were having adenocarcinoma, and patients with poor performance status was allowed. Patients with baseline brain mets were allowed, and comorbidities were present. And 318 patients were recruited in this study, and we see that median follow-up time was 9.6 months. Median time to next treatment was found to be 17.9 months, and median time to treatment discontinuation was 17.2 months. So we see that this follows the same principle, that there is the effectiveness of osimertinib, and longer follow-up data will receive the further analysis will be needed. Further data is supporting the fact that osimertinib should be preferred as a first-line treatment. Next slide, please. Next slide. So with the use of the trial data and what the real world scenario says, what the guidelines says, and guidelines, first the NCCN guidelines. Next slide, please. We see the NCCN guidelines preferred choice of TKI is osimertinib with the approval of category 1, especially in the patients who have not received the first line therapy. In case first line therapy, chemotherapy have been received, then as a maintenance, osimertinib is again preferred as a category 1 drug. Next slide, please. So from NCCN, we come to the ESCO guidelines. In ESCO guidelines, if there is a sensitizing EGFR mutation, then osimertinib with monotherapy is the preferred choice of treatment as compared to the other drugs. Next slide, please. So to conclude my presentation, osimertinib is the only tyrosine kinase inhibitor which has demonstrated a clinically and statistically significant improvement in overall survival. The median OS benefit of greater than 3 years has been proven with the use of osimertinib, and there's the single TKI which have shown this OS benefit. Flora is the first time an EGFR TKI translator has shown a translated benefit of PFS into an OS benefit. Approximately 30% of the patients who started osimertinib continue osimertinib at the end of 3 years. It is the only drug which has shown the benefit in the patients with brain mets and with the patient who have T790 mutations. It is shown to be safest and least toxic of all tyrosine kinase inhibitors among the available options. So some studies have raised the concerns of pneumonitis with it. Sequencing cannot be considered the best strategy, as approximately 70% of the patient population are not eligible to receive osimertinib in second line because they don't have the resources to check the mutations, and approximately 30 to 40% patients who are not fit to receive second line treatment. So all these data establishes the role of osimertinib as a first-line standard of care in the metastatic EGFR-mutated lung cancer, and this is reciprocated in our guidelines. So I thank you, and if any questions are there, I would be pleased to answer.
Thank you so much, Ankur sir, for the talk. So now I thanks all for joining today's webinar and have a good night.